about newborn screening in CF. I'll give you just a little bit of background about newborn screening for CF in the US. And then I'm going to spend most of the time focusing on our new guidelines that were just published in the US by the CF Foundation, consensus guidelines for CF newborn screening, and then an overview of our processes and some of our QI work that we've done. So newborn screening was developed and pioneered by Dr. Guthrie, who used this technique to detect PKU in the 1960s. So it's not super old. Dry blood spots on cotton filter paper were really considered the most cost-effective means of population screening and continue today. And for newborn screening for CF, in 1979, IRT was measured for the first time in dry blood spots. And in 1982, the first state in the US began CF newborn screening, that was Colorado. In 2005, the American College of Medical Genetics recommended CF newborn screening become routinely done. And in Michigan, they had the first conference to start planning and working on this. Actually, in 1999, I skipped that one. And then in 2006, really Michigan got moving on this and started working towards planning. And later that year, the state legislature approved funding for screening for CF, and we began screening in 2007. So just this year, these are hot off the press new guidelines that came out. CF newborn screening, a systematic review-driven consensus guideline from the US CF Foundation. A lot of this work was driven by concern for disparities in newborn screening and CF within the US, but I think really applies here as well with the differences in mutations that you guys see and the rarer mutations. Newborn screening for CF, again, is performed in many countries worldwide. It's been performed in all the US states since 2010. But variations among the states in the US in terms of algorithms followed, follow-up practices, etc., can lead to differences in equity, sensitivity, and timeliness of intervention. And individuals from historically marginalized races or ethnicities have been disproportionately impacted by this, by these differences. So it was recognized early on that the routine CFTR panels that have been used in CF newborn screening frequently included only the 23 variants that were recommended for carrier screening in pregnant women, etc. That these really favored the identification of non-Hispanic white infants with CF. So when thinking about why is this important, well, implementation of CF newborn screening, it has been associated with improved nutritional outcomes, better lung function, even when you account for improvements and advancements in overall care. Even when you account for that, newborn screening still improves things further. The earlier age at sweat testing, clinical evaluation, or hospitalization at a CF center is associated with better outcomes long term, and delays in diagnosis or clinical care due to inequities in the screening algorithms or misconceptions about risk for the disease really are contributing to ongoing health disparities among, especially in our country, Black and Hispanic populations with CF. So these were sort of the rationale and goals for the guidelines. There were no consensus recommendations for best practices for CF in the US. They determined that a reasonable goal for newborn screening programs is a 95% sensitivity or true positive detection rate for all infants with CF, with equitable ascertainment within major ancestral subpopulations based on the known variants in those populations. So this report is a product of the Newborn Screening Initiative, which really came out of the recognition of increasingly diverse CF populations, CF newborn screening being more readily available, and sort of the convergence of the CFTR2-driven expanding variant pathogenicity, really seeing the advancements in sequencing and the cost coming down, so there's more availability for genetic testing across the board. So the goal was to improve equity and reduce disparities in the diagnosis and outcomes across races, ethnicities, and ancestral groups. So they made several recommendations that all had full agreement amongst their panel, and I'm going to go through these in a little bit more detail, each of them, but I'm just going to show that there were 7 major recommendations, 2 regarding immunoreactive trypsinogen, 3 regarding CFTR variant testing, 1 about sequencing, and 1 about communication. So the first recommendation, they recommend the use of a floating immunoreactive trypsinogen cutoff over a fixed cutoff. So when we start, most of the states in the U.S. begin with an immunoreactive trypsinogen level that's high. Our state and many states use sort of a floating cutoff, so it's above the 96th percentile for that batch of testing, as opposed to a specific level as a cutoff. And the recommendation is to use this floating cutoff because those infants who are missed by newborn screening often have an IRT value that's below the threshold in the first algorithm when a set cutoff level is used, as opposed to the floating level. The missed cases are more frequently in states, again, with this fixed cutoff. So the floating cutoff is expected to minimize some of the other factors that impact IRT levels, changes in temperature, especially during seasons of climate changes, differences between kit to kit or lot to lot variation, and this can really result in fewer missed cases. So the floating cutoff, however, will not adjust for infant-specific circumstances. So it won't adjust for infants who are under birth stress or other things like that. The second recommendation is that a very high IRT referral strategy in newborn screening programs should be in place if the variant panel that is used does not include all CF-causing variants in CFTR2, or does not have a variant panel that achieves at least 95% sensitivity in all the ancestral groups within that state. So this is a new recommendation, and we're actually, I think, going to have to look at our data, Samia, and maybe a good way to push towards full sequencing as well. So the very high IRT strategy involves designating infants as screen positive if the IRT measurement is above a very high threshold. In our standard group, we use 99.9th percentile, but even then, I'll show you our project later, we've considered those negative screens, but have sent letters to allow people to recognize that there may be some issues and that they should have a low threshold for testing in the future. But this is saying that the strategy results in many referrals, right? If you do this, you get many more referrals, but few diagnoses. And so a lot of people did eliminate this portion of things, but now what they're noticing is that we are identifying infants that would have otherwise been missed, and often these are those marginalized groups. So that's where the recommendation comes from. The third recommendation is that CF newborn screening algorithms should not limit variant detection to Delta F508 or just the 23 standard screening mutations. I think that's pretty straightforward. The fourth recommendation is that CF newborn screening programs screen for all CF-causing CFTR variants in CFTR2, and I think this is going to help us push the state forward in Michigan. So even when screening is performed for using extended variant panel of even 100 mutations or more, the sensitivity is often below that 95th percent mark, and it's much lower in non-white populations. Screening for all the variants that have been interpreted in CFTR2 would really be helpful in picking up some of these other marginalized groups. And it can be achieved using sequencing. So programs can choose to refer only infants that have 2 CFTR variants for sweat testing after full sequencing, and so you can cut down on some of the sweat testing referrals in that way. They recommend conducting variant screening twice weekly or more frequently as resources allow. You don't want to wait too long to make diagnoses, so if you don't actually run the sequencing frequently enough, you're going to have some babies that are delayed in their diagnosis. Then they recommend the inclusion of a CFTR sequencing tier following IRT and CFTR variant panel testing to improve the specificity and positive predictive value of CF newborn screening. So many states like ours start with IRT, and then they go to a limited panel, which might be, ours right now is 60 some mutations, it might be 100 some mutations. But then what they say is people who don't have mutations picked up on that should go to a third tier of full sequencing. And this really improves the sensitivity and specificity. They recommend that both primary care provider and the CF specialist be notified of the abnormal newborn screening results. Infants with a positive newborn screen that are identified by state programs, families want to be notified by people who they know and trust, and that's really their primary care provider. But they want to receive information from someone who's also very knowledgeable, and so they really do need a specialist as well. Infants from Asian, Black, Hispanic, other multiracial or other populations, when they get the results communicated back by the PCP, they may have delayed referral if the CF doc is not involved, because there's a misguided perception, right, that CF only affects non-Hispanic white babies, and so this doesn't really apply in this case. And so the referrals are delayed there. So by notifying both the primary care doc and the CF specialist, we really increase the likelihood of a correct assessment and understanding that risk and not having misperceptions by either the doctor or the family, leading to delays and difficulties with actually wanting to move forward with care, because we do have some families who then also feel like, well, my primary care doctor didn't think this applied to me, and I don't see this in my culture, so I don't think it's really something I should worry about, and they don't pursue care from there. So they also, I'm not going to go through these, this is just to say that they also made several other not as research-based recommendations and suggestions as well. This is just to show, this is sort of the IRT DNA way of doing things, where you have a high IRT, some states do a second IRT, and then you do a CFTR panel, and then if that panel has 1 or 2 mutations, you go on to sweat testing. And the recommendation is, with that extra tier, start at IRT, go to your panel, and if you only get 1 variant or a very high IRT, go to full sequencing here before moving on to the referral for sweat testing. And this is just their schematic of how the whole process works, but I'm going to show you what Michigan does. So this is the state of Michigan CF newborn screening protocol. It's quite elaborate, and we have several of these. But just to walk you through the basics, we start with an IRT, and if that IRT is greater than or equal to the 96th percentile for that batch, we move on to mutation analysis with a panel. We're hoping to expand this panel over time. If we have 1 or 2 mutations, those patients are referred for sweat testing. And this goes to our newborn screening lab. They reach out to the primary care physician. They make sure the primary care physician sends a referral in for a sweat test at one of our accredited CF centers in the state, and that they notify the family of this so that they can move forward with scheduling. If you have an inconclusive test, I think this is extremely rare, that the test itself doesn't work right, then you have to relook at things. We send things off to a special lab to relook at that section that was in question, and hopefully either come to 1 or 2 mutations and move through that same pathway, or no mutations and move through this pathway. So here, if we have no mutations and the IRT is not very high, this is a negative newborn screen, no further action is necessary. In this rare case of, excuse me, of this inconclusive testing, we would send a letter to just say, hey, there was this one area of concern that if you see symptoms or there's family history, we should probably send a referral. And then for us, if we have no mutations and a very high IRT, we still consider it a negative strain, and I'll show you why in a couple minutes. But we do send the same notification letter letting families know that if there is family history or symptoms or signs of CF, they should be referred. So we come down to our sweat testing. If we have this is sort of more standard in terms of understanding if you have a positive sweat, if you have an indeterminate sweat, if you have a negative sweat. I probably don't need to run through this part as much with you. We do get into a diagnostic dilemma situation where we have 2 mutations with a normal sweat, or 1 mutation and an indeterminate sweat, where then you're sort of, what do we do with this, right? Where does this go? So that's what we call our diagnostic dilemma protocol, and it outlines what to do in all of those situations to try to come to some resolution. And then these are some other scenarios that become challenging: intermediate sweat chlorides with 1 mutation, and quantity not sufficient with 1 mutation. Where do you go with that? And these again are really detailed algorithms to help walk through and try to come to resolution. But I wanted to just talk a little bit about the work that was done for very high IRTs with no identified mutations. When Michigan first began our program, we did report those very high IRTs with no mutations as positive, and infants were referred for sweat testing. But when we reviewed our data over the first 6 months of testing, we had over 120,000 infants screened, almost 7,500 had repeat IRTs, 99 infants fell into this, very high IRT with no mutations, but none of them ultimately were diagnosed with CF. It turned out that the vast majority of these were babies in the NICU who were under stress. And that is oftentimes the case of those very high IRTs. Those are babies under stress. And so with that, we went ahead and changed our algorithm to say that that's a negative screen, but again, we send that letter back to families and the primary care doc letting them know. We did look at the variation in IRT and race over the first year of our program here. Again, a large number of babies screened. The mean IRTs percentiles did vary significantly by race, birth weight, gestational age, fetal growth, and to a lesser degree sex. And the greatest variation seemed to be race, and so the mean for whites might be 28 nanograms, whereas blacks 36 and Asians 25. So you can see certain populations were higher, others were lower based on race. And so these were all the things that we considered as we made these guidelines. So as a result, again, we made a change to the way that we do things. And now with these new guidelines that came out, we'll need to relook again and see where we fall there, I think. The last thing I wanted to chat about was just improving parent and primary care provider understanding of positive CF newborn screening results. In our experience, there were a lot of parents that misunderstood the significance of their initial positive newborn screening results, and multiple revisions of the PCP, the primary care notification letter, did not fix this. So it was clear that the primary care physicians also were not understanding what was coming back in terms of newborn screening. And this led to increased anxiety for families, increased utilization of healthcare, and a lot of dysfunctional parent-child relationships. So a project was undertaken to really assess both parents' understanding of their newborn screening and then the primary care's management and understanding of the newborn screening results, and then use this to develop better communication tools for families. I'm going to skip through a little bit of this. We sent out surveys to families and did some semi-structured interviews of parents who said that they misunderstood these letters. And then we mailed surveys to pediatricians and family practice physicians in Michigan, giving hypothetical scenarios and asking them to interpret these results and identify the challenges in communicating with families when they're in this scenario of not necessarily fully understanding those results. And then again, work to develop an educational tool that would help improve this. So it's really important that PCPs effectively manage the initial disclosure of the results. And we see this all the time when families come and we'll see that they have 2 mutations on their newborn screen, but they were told that they don't have CF. This is just formality and they're probably a carrier. Or the other way that they have 1 mutation and they must have CF when they're only a carrier and they're coming thinking they have CF. Intervening with physicians is a realistic option. It does improve the efficacy and quality of the newborn screening process. The physicians do want to understand this, but it is a challenge to get them to understand it. But strategies for improvement might include multifaceted interventions focusing on physician confidence and better information transfer and better information to the families. Thank you.
Thank you so much, Dr. Amy. This was a very interesting presentation. I have a question for asking other people, because we had a restricted program to do screening for CF for using RNRT in the NICUs, in like using high-risk babies who are already admitted to NICU. And I think Samia would like to comment on that as well. And apparently this was not a very good experience to screen for CF.
Right, so the group that Amy presented, that the 99 patients that we had that ended up, none of them had CF, was what you're doing now. So what you're doing now is what we did, which is all the patients that have very high IRT, ultra high IRT, were all in the NICU and they died. A lot of them died before we got into them. Or they were preemie, because IRT can be high in other situations than newborn screen, than CF. So it can be high with sepsis, it can be high with prematurity. So you really are setting yourself up. So in Michigan, for example, we have about 120,000 births a year. I know in Egypt a lot more, but in just the state of Michigan. And 5,000 of them will be high IRT. So we go back, and after that we go to mutation analysis. And in Michigan, we used to do 60 mutation, or we used to do 30, increased to 60, and now we're at 139. And then if the patient has 1 mutation or 2 mutation, we sweat them. So in here, I know they do some mutation after the IRT, but again, the population, and I told them that from the very beginning, because I was involved in the first parts of the newborn screen, and I said, you guys are not going to have many patients, and then you're going to say that the newborn screen is not successful. Well, it's not, because it's designed in a way that's not really correct. So right now, they've been doing the pilot for several years. Okay, great. I did get some cases. So I think there's some, a few cases that they told me last year that was positive. And I told them to make sure to follow them. They have a high IRT, but they also have mutations. And I think they tested for the 30 mutation. I don't know how many they tested for. But it's time to do it across ages. Okay, you did a pilot, what's the next step? The next step is to generalize it. Because once you start, because you really know the incidence of the disease when you do the newborn screen. Because right now, what Mr. Ikram reported, 1 in 2,500 is way, way high. There's no way. It's like in the US, it's 1 in 3,000. So it cannot be 1 in 25 or 26 or something. So I'm guessing it's 1 in 6,000. So with that, we need confirmation. So the only confirmation is the newborn screen. So I didn't bring that up when I went to Dr. Hassani, the assistant to the Minister of Health, because I have other issues to talk to him about. So we didn't really talk about newborn screen. But I will be talking to other people and emailing him about it too, because we really need the newborn screen to be generalized over Egypt.
I wonder if they do the initial newborn screen and then they repeat it after like a couple weeks in the NICU, because I know that that's what we do when we get like a sort of inconclusive result because the kid is in the NICU. We tend to repeat the newborn screen a couple weeks later.
We don't repeat it.
Okay.
Even the ones where they were repeated, Sally, were still also often falsely high.
Oh, okay.
Yeah, we only do the newborn screening once, and followed, like, we do the IRT, and then they followed by, we actually call them if there is a baby of a mother with CF to run the test anyway, even if they have low IRT, or if they are on Trikafta, the mom is on Trikafta, and then the baby might be normal because, we have Trikafta going through to the baby. So we usually ask them to run the mutation, not the IRT.
Yeah, Trikafta has definitely brought up some new challenges with newborn screening.
Yeah. So there's a lot of work in Egypt. But the good news is that the pilot is done, so we don't need to do another pilot. What we really need is to push for it to be around the country, which they are doing for other diseases, so just add CF to it. So.
Thank you. Any other questions? Thank you.